there seems to still be people. So I want to say good afternoon, everyone. I'd like to welcome all students, faculty, staff, alumni, and parents who are joining us today for a presentation on cutting through the COVID noise, where we are, how we got here, and what comes next. For those of you that have attended previous forums for the past 2 years, Dr. Rondello and members of the Health and Wellness team have been having open forums to discuss everything from COVID safety plans to reopening our campus, to mental health concerns and issues, anxiety, and they've been really quite successful and informative. One of the most common requests that I get at the end of each of the presentations and forums is, I wish we had more time to hear from our university epidemiologist, Dr. K.C Rondello. So I had thought that this is a good time for us now to be able to have our lunch, be able to sit back and kind of give the whole stage to Dr. Rondello, where we can listen to his expertise, take notes, and of course, if anybody has any follow-up questions or concerns, we ask that you email healthandwellness@adelphi.edu, healthandwellness@adelphi.edu, and one of the members of our team will be happy to get back to you. I'd like to remind everybody that this presentation is being recorded. So sit back, relax, enjoy your lunch. And other than that, I'd like to welcome now our university epidemiologist, Dr. K.C Rondello. Casey?
Thanks, Gene. Such a pleasure to see everyone. I see we're coming up on 100 participants now, which is fantastic. And I'm delighted to have the opportunity to share with you some thoughts. Same, Gene, whenever I get a chance to speak, and it's usually, give us the history of COVID-19 and where you think we're headed and what's about to happen next, and you have 5 minutes. That's usually what happens in most of the meetings that I present at. So the idea of having a nice chunk of time where I get to go into another layer of depth, cover a bit more than I normally get a chance to do, is one that I heartily welcome. And so thank you for giving me this opportunity, and welcome to everyone. I'm going to share my screen and then we'll get underway. Someone just give me a heads up and just let me know for sure that you can see my screen.
You're good, Casey.
All right, thanks, Jim. All right, so many of you know me in my role at Adelphi as a university epidemiologist and faculty member now for almost 20 years, now clinical associate professor in the departments of public health and emergency management in the College of Nursing and Public Health and the College of Professional and Continuing Studies, respectively. But I'm not sure if everybody knows about my life and my world outside of Adelphi. So just to give you a little bit of a flavor, a little bit of a taste as to how I ended up being a professor and what expertise I bring to the table. As you can tell from my credentials, I am a physician with a master's degree in public health and a specialty in disaster epidemiology. We'll talk about that in a moment. CEM is Certified Emergency Manager, which is a credential of the International Association of Emergency Managers. For about 20 years, I served as a disaster epidemiologist with the U.S. Department of Health and Human Services on their National Disaster Medical System team, MSET. I know the federal government loves its alphabet soup. Multi-specialty enhancement team. And prior to coming to Adelphi, I was the founding director of the Center for Healthcare Preparedness, which is a HRSA-funded institute that was established to further education and research in the field of medical disaster readiness. Probably, I often get asked, well, what do you do for fun? What are your hobbies? Probably my biggest thing that I do with my time when I'm not working is that I'm working. I do a lot of before COVID, a lot of international global medical and public health service work. I partner with a number of NGOs. There are a few listed on the slide, and that has brought me to almost 20 countries on 5 continents, fighting disease epidemics, certainly things that you've heard of, like Ebola, Zika, H1N1, SARS, MERS, and others, and many that you frankly haven't heard of because they haven't largely impacted the area where we live. But that's in a nutshell the expertise that I have outside of Adelphi that brings me to my role as university epidemiologist and professor over in CNPH and CPCS. When thinking carefully about how I wanted to spend our time today, God knows I could do an hour on just, I don't know, vaccine boosters alone. And so even though it sounds like a lot of time, I wanted to use it as judiciously as possible because I know it's going to go pretty quickly. So this is how I thought we'd spend our time today. I'll lay a little bit of foundation talking about epidemiology in general, the work that I do, about epidemics, pandemics, because those terms oftentimes by the media and others are used interchangeably when in fact they're very different things. One of the questions I get asked most often on my top 10 FAQs is, where did COVID come from? Is this a weapon? Is this something that came out of a lab? Is this? So I want to say a few words about emerging infectious diseases, teach you about some of the tools that we epidemiologists use in doing our job. Throughout the pandemic, I've pretty closely been able to chart precisely how this is all going to play out. And for some, they think this is some kind of voodoo magic, but in fact, it's nothing that any good epidemiologist couldn't do because this is our science. This is what we've studied for generations, and this is what I professionally have done, since graduating from medical school. So I want to orient you to a few of the tools that we epidemiologists use, some of which you see all the time whenever you open an article online or a newspaper about COVID-19. The epidemic curves, I'll talk a little bit through the epidemic curves, about the R number. And then of course, the bulk of the presentation today, I want to talk about COVID. Yesterday and today, what brought us to where we are today. I will say a few things about vaccinations, but I don't want to spend a whole lot of time on that so that I can get to what comes next. Talk to you about what I call the COVID end games, the scenarios for the future, and also show you some well-respected models that predict what is going to happen next. Hopefully within all of that, there'll be some good news. Unfortunately, there'll likely be some bad news. But at the end of the day, when you log off of here at the end of the presentation, my goal is simply to have you walk away knowing something that you didn't know right now. And I feel confident that we're going to be able to achieve that goal. I'll conclude our presentation today with just a few final thoughts, make it a little philosophical with you at the end, because as we enter this new phase, this new chapter of the COVID experience, I have a few thoughts I want to share with you, and then that'll be it. And then that'll round out our time together. So a bit about me and what my life is like. Let me tell you what it's like when I go to a cocktail party. You've all been to plenty in your life. So, inevitably you end up mingling. In my case, it's usually by the food. And you end up in small talk with people who, want to make chit chat. And of course, one of the first things that comes up in cocktail party banter, and this is the case whenever I'm at one, inevitably turns the discussion and I get asked the question, oh, what do you do for a living? That's usually the point at which I have to make a choice. I can either lie and say, I'm a pediatrician, at which point the person who's asking will likely go, oh, that's nice. And the conversation ends and then they walk away. That's the neat and clean answer. But of course, that's not truthful. If I really am able to stomach it, what I'll usually do is I'll take a big deep breath and I'll say, well, I'm a physician. And then they'll say, really? What kind? And I'll say, well, actually, I'm a disaster epidemiologist. Furthermore, I am I specialize I'm an epidemiologist and I specialize in disasters. And the first thing they usually say is, oh, you're a skin doctor. What does that have to do with epidemics? Or what does that have to do with disasters? And then I have to take a step back and say, no. Actually, epidemiology is the study of epidemics. It's the science of public health. And as a disaster epidemiologist, I specialize in emerging infections, weapons of mass destruction, bioterrorism, and chemical, nuclear, radiological, and explosive devices. And that's when they usually, they drop the food, they make some polite excuse to leave, and then they start backing away. So I don't think I'll ever have to have the explanation of what an epidemiologist does again in my life, sadly. I think that everyone on the planet at this point knows what epidemiologists do. Epidemiology, as I said, is the science of public health. It's the quantitative, meaning it's data-based, numbers-based study of the distribution and determinants of health-related events in human populations. And since I'm a disaster epidemiologist, I specialize in the application of epidemiology in disasters. Now, if the outcomes of these disasters, be they emerging infections like COVID or otherwise, were completely random, then I wouldn't have much of a job and there really wouldn't be much science to my discipline. But that's not the case. We know that adverse health outcomes from crises occur in somewhat predictable patterns. And therein lies the key that makes epidemiology a science. It allows us to assess both the short-term and the long-term consequences of a health event, usually before any information is even collected, so that we can predict, and if not prevent, certainly mitigate the consequences of future disasters. That's the, in a nutshell, rubber meets the road definition of what it is that I do. Now, you've heard the terms epidemic and pandemic, and there was a lot of talk in the media about is this in fact in the early days, was this an epidemic? When does it become a pandemic? And there's this idea that a pandemic is just a more severe epidemic. And that's not the case. So let me just go over a little bit of semantics and define for you three terms that are really important: endemic, epidemic, and pandemic. In most populations, for many diseases, there's a baseline level of disease activity that we always expect. Think common cold, Garden City, New York. So at any given time, there's a baseline level of folks that are infected with one of the cold viruses, and they have the symptoms of the cold. If we were to survey the population and gather data on the number of cold cases, we would likely not make ourselves crazy, because what we see is most likely what we expect. And that's the usual, seasonally expected, geographically expected, endemic baseline level of disease. What's endemic for a given disease is specific to time. In other words, what's endemic for Garden City in November is different than what's endemic in Garden City in July. Okay, so endemic is specific to time and specific to place. What's endemic to Garden City is not the same thing as what's endemic in Southeast Asia. But as we gather information on any disease, okay, we have to factor in, what do we normally expect to see? What's our seasonally, geographically expected baseline level of disease for that pathogen? That gives us our endemic level of disease. Now, periodically, a disease will come along in either time or place, and there will be an outbreak or a rise above what is endemically expected. We may see a statistically significant spike, and there are ways for us to calculate this mathematically, spike above the endemic level of disease. When that occurs, we have what's called an epidemic. All an epidemic is, okay, is when there is a sudden increase in cases that's spreading through the population in a given area, and that increase is statistically significantly above what we would expect in the endemic level. That's an epidemic. We reached epidemic proportions for COVID pretty early on. Now, many people think, okay, well, is pandemic the next level? In other words, is when it gets bad, it go from outbreak to an epidemic, and then when it gets even worse, go from an epidemic to a pandemic. And that's not entirely the case. It is true that pandemics typically are worse than epidemics, but all a pandemic is two or more epidemics of the same pathogen occurring at the same time in two places on Earth, usually interpreted by epidemiologists as two different continents, two widely separated geographic spaces. So when we end up having epidemics of the same disease occurring in multiple places around the globe, particularly on different continents, we have what technically is called a pandemic. Now that's the actual public health definition of what a pandemic and an epidemic is. I'll tell you something I never really considered the impact of is the psychological impact of the word pandemic. And what I mean by that is that very early on in the COVID experience, it was clear that we met the definition of being a pandemic. I mean, this epidemic of this novel pathogen was occurring on, certainly more than one continent pretty early on. But for reasons I didn't really appreciate, frankly, until the COVID experience, the media, the World Health Organization, the Department of Health and Human Services of the US, they were very loath to use the word pandemic, even though it certainly met the definition well before we started using that word. The word pandemic infers things to people, certainly to lay people that don't understand technical definitions. And when that word started to be used, even though it was appropriate, it understandably created some degree of, oh my God, this is really even more serious than an epidemic. So there's power to the word as well, pandemic and epidemic, which is different than perhaps the actual medical definition. Now, let me say a few things about emerging infectious diseases. COVID-19 and SARS-CoV-2, which is the virus that causes the disease COVID-19, is an emerging infection, the disease, and an emerging pathogen. It didn't exist before. Up until just a few years ago, as you well know, this is not a germ that humans had ever faced. We, as humankind, the word in epi is novel, we were novel to the infection. No body, physical body, had ever experienced that pathogen before. Sadly, I'm sorry to inform you, but the number of newly emerged newly emerged infections that occurs, that number has been growing and growing and growing exponentially. In fact, the number of brand new pathogens, novel emerging infections in the last 10 years is greater than the number of emerging pathogens that have occurred in the preceding century. This graph gives you some idea of, this is from Nature, Nature magazine. This gives you some idea of the growth in just the last few decades of emerging infectious diseases. Now, most of these emerging infectious diseases that are coming on scene are what are called zoonotic diseases. Zoonotic diseases are those diseases, those pathogens that cross species boundaries from some other animal into humans. Now, just because you have a zoonotic disease does not make for a pandemic, an epidemic or a pandemic, right? There's lots of zoonotic diseases. That's not where the problem necessarily lies. If you have a zoonotic disease, then those who come in contact with the animal that the disease originated in, or the animal's byproducts, or its meat, or its feathers, or whatever, people that come in contact with that animal are potentially at risk. But therein does not lie an epidemic. Where we get into trouble, and when we start to see an emerging infection, a zoonotic illness, become potentially catastrophic, is when the pathogen emerges and evolves. It evolves in such a way that it can now be transmitted not just from animal to human, but from human to human. Not all emerging pathogens do this, but you know about genetic shift, you know about the fact that these diseases are constantly changing. And if you have a zoonotic illness that somehow manages to figure out how to go from person to person, then all bets are off. Then we have a problem, because then you're not just worried about the kids that clean up after the chickens when it comes to bird flu. Okay, big issue in parts of the world. But now we have sustained human to human transmission, which means you can get sick if you were never near the chickens. And that's when we get into really problematic acceleration, exponential growth of an outbreak. Okay. All right. Why is it that these emerging infectious diseases are occurring at an alarmingly accelerated rate in the year 2021. There are lots of reasons, and it's a whole lecture in and of itself for me to talk about these, but I want to cover a few of them. We are dealing with an accelerated rate of emerging infectious diseases, most of them zoonotic, for many reasons. Number one, the pathogens are evolving. They are adapting. They are learning to figure out ways around not just our innate compensatory mechanisms in our immune systems, but also against the pharmacoprotections that we have to protect ourselves against them, be that medications or vaccines or otherwise. People are living longer. People that, and this is largely a good thing, right? You all know that the average age of an individual continues to climb each year. And that's because we have lots of technologies to keep people alive and survive diseases and medical problems, chronic illnesses that would have cost them their lives years ago. We now have the ability to have them survive. The thing is that while people live longer, that's a good thing, of course, but your immune system works less effectively with age. And so as people live longer, we're increasing the percentage of folks in the general population who have suboptimal immune systems. So the aging population is certainly one component of another reason why there's an acceleration in emerging infectious diseases. You can't discount global warming, climate change, the tearing down of rainforests, places where humans never were, where there are pathogens that now are being introduced to the human population, certainly a factor. Human demographics and behavior, not only is global population increasing, but more importantly, as it relates to emerging infections, the population is becoming increasingly concentrated, which means there are larger and larger numbers of people for sure, but they're concentrating disproportionately in urban areas. Cities in particular are growing at an astounding rate. And in those areas, people are obviously living in a lot closer proximity to themselves, to others, than they would have in years past. So our human population growth, a big issue, but where that growth is really occurring, which is in urban centers, a big part of that. International travel, obviously, that's one that you probably could think of yourself. It used to be that it would take months for a pathogen to circumnavigate the globe, only a few decades ago. And now, of course, we have a situation where within 36 hours, a pathogen can traverse the planet. Okay, and there's other measures, there's other reasons here I can go into, the breakdown of some of our public health measures, the development of, war and mass migration, population displacement, think of Sudan as an example, lots and lots of reasons, all right? So in terms of where did COVID come from, very early on in the pandemic, I was asked to do some consulting with the FBI. And one of the conversations I had with FBI early on was, where did COVID come from? COVID came from where SARS, MERS, Zika, Ebola, all of these new emerging pathogens have come from. These are frankly just something that we will increasingly need to learn to live with, is the advent of these novel pathogens for which humans are naive. That is the explanation of where COVID came from, and sadly, it's not unique to COVID. In other words, there will be other emerging pathogens that we will inevitably face in our lifetime. Let me talk a bit about some of the tools that we epidemiologists use, one of which is called the R number, or the reproduction number, okay? The reproduction number is the number of new cases of a disease that are caused by a single infected person. Okay, so think about this for a second. If you had an R number of 1.00000, exactly 1, then your epidemic would neither grow nor would it dissipate. Because with an R value of 1, for every person that's sick, by the time they recover, they have infected one additional person. And when that person recovers, they infect one additional person. And so basically, if you have an R number of 1, exactly 1, then the whole number of cases at any given time doesn't grow and doesn't shrink. It's basically constant. So any number above 1, then more than 1 person is getting infected for each sick person. And so if you have over time an R number of greater than 1, your pandemic is growing. And the larger the number is, the faster it's growing. And what we look to as an early indicator of are we getting better or worse when it comes to a pandemic is the R number dropping? Ideally, as far below 1 as we can get, because any number below 1 and the whole number of cases is shrinking, because any number below 1 and there's less than 1 person for every newly getting infected for every recovery. So where are we now? Well, this is New York's R number, and I'm happy to demonstrate that the R number for New York has been dropping. It's now 0.82. And when we see any number again that's below 1, it means that for every person recovering, there's fewer than 1 new person getting infected. The lower that number gets, the slower the spread of the disease. And over time, the lower that number gets, the faster that your population of sick people shrinks. Okay, that's the R number. Another tool that you have maybe even more experience with as you've been looking at articles and you've been learning about COVID is the epidemic curve. Epidemic curves really are the bread and butter of tools for the epidemiologist. An epidemic curve is a tool that we use to investigate an outbreak and shows changes over time. So this is a very simple epidemic curve you see here. The time of some factor, usually daily or weekly, is on the x-axis, and the number of persons sick usually is on the y-axis. All right. This allows us to conduct a continuous, ongoing assessment of the disaster condition. And we're going to look at some epidemic curves for COVID in just a moment. What can we learn from these epidemic curves? Well, we get a lot of information from the epidemic curves. First of all, it helps us to define how big the outbreak is, or what the magnitude of the epidemic is. Okay, how many people are sick? What's the trend? Looking at the line, the curve of the epidemic, are we getting better? Are we getting worse? Are we in a situation similar to that we were at a previous point in the epidemic? Okay, did we hit our highest point, or is the worst yet to come? When we're initially doing the disease detective part of epidemiology, and we have a bunch of sick people and we don't know from what, the epidemic curve can also help us determine how the outbreak is being spread. I'll show you an example of that in a minute, okay? By looking at the pattern of the curve, we can make some inferences and implications as to what's going on here. How is this going from person to person? Okay. We can also look at timelines. When did symptoms start? When was the final case report, and so on? These are 3 very simple epidemic curves: a point source epidemic curve, a common source epidemic curve, and what's called a propagated outbreak epidemic curve. Okay. So what do we see here? The first one, we see point source epidemic. We see that there were a lot of people who got sick at one time with a rapid rise and then a relatively slower fall, okay? A lot of people got sick at once and then started to recover. The quintessential example of a point source epidemic would be the potato salad at the church picnic, okay? Everyone ate it at once, everyone got sick at once, then people started to recover. A continuous common source epidemic would look like the second chart. This is where you see, first of all, the disease occurring over a longer period of time, but you see certain people getting sick and then recovering over, think of it as a squashed bell curve, okay? In other words, there was contact with the source of the epidemic, but over a longer period of time. There was a slow increase, a slow decrease, and then it's over. A good example of this would be the poisoned well, okay? So there's something wrong in the well, there's a pathogen. As a result, people are coming up to the well, drinking the water, but they're doing that over a period of days, weeks, months. And so that's what the epidemic curve is going to reflect until we correct the problem, we sterilize the well, and then problem solved. Finally, there's a propagated outbreak, and this one should look a little familiar to you. There is no common source agent for an outbreak, for an epidemic like this. There is person-to-person spread, and what you're going to see is successive peaks and periods of recovery, peak, period of recovery, peak, period of recovery. These peaks coincide with each incubation period of the pathogen, and of course, spoiler alert, propagated outbreak type epidemic curve is indicative of an infectious disease. COVID would be a propagated outbreak. So now that you know something about different epidemic curves, let's take a look at both the US COVID curve and the New York COVID curve. So this is as of this morning. This is the United States COVID curve of new cases. And you hear in the media, you hear people talking about waves or crests. It's very easy to see these when you're looking at it graphically like this. This is the beginning of the pandemic. This is the first wave of COVID, which doesn't look all that bad. But remember, this is national data. When we look at the New York data, you'll see a marked difference in this period. But this is wave 1. Then we have a period of relative respite before wave 2, which occurred during summer of 2020. It looks worse than wave 1, and for much of the country it was. But for those of us in New York and the Northeast region, wave 1 was worse for us. Then there was the fall break until finally the big bulk of the epidemic occurred. This is wave 3. I'll tell you that when we were decimated during wave 1 here in New York, probably one of the hardest parts of my entire career was knowing that this was to come, and thinking of the way after people had just completely been obliterated by wave 1 in New York, feeling as if we finally got over it, knowing that the worst was yet to come, and having to communicate that message to people, I'll say, was certainly one of the toughest challenges of my career. This, you might say, what's the deal with this? Depends on the model. Sometimes this is considered a wave. For our purposes, we won't call it one. But this is the period when things were their best. This is when COVID vaccination was at its highest. This is when protective measures were at their highest. Okay, and this was pre-Delta. This is when things were looking at their most optimistic. Unfortunately, you see that it didn't stay that way, right? This is when the Delta variant emerged, more communicable, more virulent, and this is when interest in vaccination sort of plateaued. And you see here, that there was obviously a very dramatic rise in cases, and this is what we got for wave 4. This is where we are now. It's a little soon to tell, but you can see that after coming off of the worst of the Delta-driven wave 4, there was a significant decrease. We seem to be plateauing a little bit, but it's really too soon to tell. Let's take a look at what's going on in New York. I'd like you to note the similarities and the differences. The waves largely mimic what happened nationally, with a few caveats. One being that our wave 1 was a lot worse for us than for a lot of the country. Wave 2 for us was absolutely negligible, but this is the period during which most of the country got its first taste of COVID. Think Midwest, Florida, and Texas. Wave 3 was the worst for us and the worst for the country. And then here you see where we are with wave 4, which stayed flat for quite some time. But fortunately, as of a few weeks ago, we start to finally see the drop off. All right, so this is national and this is New York. Let's take a look at the last few weeks of Nassau County data. I lost my screen here for a sec. In Nassau County data, and you can see that we, although it's not dropping off at the rate that it would be nice to see, we are definitely starting to see, a decrease from where our peak was over the highest of wave 4. All right, so let's take a look at some numbers. This is a numerical representation of what you just saw, both in terms of cases and in terms of vaccinations. There are a few numbers that I really want to bring to your attention. Okay. One, note that overall, the percentage of new cases is dropping along with the percentage of new deaths every day nationally. This drop started before the drop locally in New York occurred, but we knew it was coming, okay? There's about a 17 to 21 day lag between the time a new case is diagnosed and until someone succumbs from that illness if it's going to take their life. This is a number to remember: 745,000 deaths in the United States as of yesterday. Okay, let's look at the New York numbers. I don't want to inundate you with numbers that numb you. Just basically pick up on the fact that cases are dropping. The corresponding deaths from those cases are dropping as well. Now, I'll tell you, there's a lot I could do a whole hour on this slide alone. I'm not going to do that, but I do want to bring up one point, and that's that we've looked at so many numbers throughout the course of the pandemic that we've just become numb to what these numbers mean. And we throw around terms like, oh, as of yesterday, 745,000 Americans have died directly from COVID-19. The number of people who've died from other diseases and COVID was a factor is obviously higher. This is simply attributable exclusively to COVID. Often it's difficult to think of what does that number mean. Again, we become very numb to it. And so I remember when we were getting into levels of mortality that began to rival how many people died during World War I, then how many people died during World War II. And so just in an effort to give you some grasp as to just how large 745,000 US deaths is, I sat down one night and I did the math, and I looked at every armed conflict that has occurred in the United States in the 20th and now the first 21 years of the 21st century. The cumulative total of all military and civilian casualties from every armed conflict that occurred in the last century plus the 20 years of this century is 640,000. Let me add that if you want to factor in every armed conflict that has ever occurred since the United States became a country, I'll throw in the Revolutionary War, the War of 1812, and the other wars you see are Spanish, Mexican, and Philippine American wars, another 60,000, and you're talking about a sum total of about 700,000 deaths. So what does that mean? That means that more Americans have died directly from COVID-19 than the total number of military and civilian casualties from every armed conflict in the history of the nation. And when you begin to compare apples to apples in that way, it definitely gives one pause, a moment to reflect on just where we are and just how bad this is. A few slides about vaccinations. Vaccinations, as you saw from the previous graph, when you saw us coming out of wave 3 and just how precipitous that drop was, that was largely driven by vaccination effort. A few things to say about vaccinations in New York. This is when vaccinations were occurring at their peak. That's basically the spring when anyone who could get the vaccine who wanted it could get it. Just a point I want to bring up here, just two things. Number one, notice that this is the number of vaccines that are delivered every day in New York. Note that it did not go down to 0. So starting in about July, it flatlined. What does that mean? That means the number of people that are coming in to clinics and doctors' offices for their first shot today is the same as the number of people who came in for a shot in July. That's very encouraging, because while we'd certainly like this number to be higher, and we'd certainly like the interest to be more commensurate with what we experienced early on in the vaccination effort, when basically we didn't have enough vaccine for the number of people that wanted it, it's important to acknowledge that that interest has not gone down to 0, and that every single day there are thousands that continue to say today's the day. I have seen the evidence that has convinced me. Today, it's finally clicked. The straw broke the camel's back. I'm going in for my vaccine. And you can see that that number has remained very steady for months now. We're fortunate to live in Nassau County, which has a higher than average vaccination coverage rate for COVID. In fact, you'll see here, Nassau County, 92% of those 65 and over, 85% of those 18 and over, and of all ages, including those who can't be vaccinated yet, for the entire population of all ages, 72% coverage for COVID-19. And I'm proud to say that makes us the fourth most vaccinated by percentage, most vaccinated county in the state of all 57 counties. There's been a lot of talk about COVID breakthrough, people who have had the vaccine and get sick nonetheless. So I would just want to spend a few slides talking about that. First of all, breakthrough happens. There is no vaccine that's ever been developed in history that's 100% efficacious. And so even in the best of circumstances, there are always going to be people who get vaccinated and get sick nonetheless, because efficacy is never 100%. But what I want to tell you is that being sick and having been vaccinated is very different than being sick and not having been vaccinated. First off, the whole number of these breakthrough cases is minuscule. And I want to demonstrate that to you graphically. Here you see these green boxes are vaccinated people, all right? The little red box down here represents breakthrough. This red box would be percentage-wise, the percentage of these green boxes that has a symptomatic breakthrough infection. In other words, people that have had the shot and get COVID nonetheless. That's the red box. And you can't really see it on your screen, but I blew it up here. And in the corner of this red box, there's a tiny little 1 pixel right there of yellow. That's the one fatality. So of all of these are all vaccinated people. Okay, this whole slide is vaccinated people. The red is the number of breakthrough cases. This yellow dot is the number of fatalities. So bottom line, the vaccines are exceptionally good, both in terms of their efficacy and their safety. They, in virtually all cases, are going to keep you from getting sick. But if you are the unlucky one who pulls the short straw and you end up being in the red box and you end up getting sick, you're going to have a much more mitigated case of the disease. In other words, you're not going to end up in a hospital, you're not going to end up on a ventilator, you're not going to end up in an ICU, and you're not going to end up dead from COVID. So even in those cases where it doesn't prevent the illness altogether, it's going to mitigate the consequences. This slide demonstrates that graphically. Here you can see viral load. That's what's being charted here. That's how much infectious virus is in your body. This the yellow line is those who've not been vaccinated, and you can see that the amount of live virus that remains within them throughout the course of their illness is high. What you see in the green are the breakthrough cases. Those are people who have been vaccinated, and you can see that while it didn't prevent the illness, it significantly led to a lower viral load, which means less symptoms and far less communicability or less risk to other people. Let me transition to the end game scenarios. Another question I get asked pretty frequently is, how does this all end? All right, there are 4 end game scenarios I want to propose to you, one of which is the one we frankly were hoping for at the very beginning of this, and that is eradication. Eradication is the total global reduction of COVID throughout the planet to the point where prevalence is 0. In the beginning, we were hopeful we could achieve eradication, but as time went on, it became very clear that eradication was no longer on the table. Okay, we will not get to the point where COVID will be gone from the globe. Certainly not in my lifetime. We will make great strides toward this, but we've only eradicated 2 pathogens in the history of medicine, one being smallpox, the second being rinderpest. And so it was ambitious to think that we could eradicate COVID altogether. This is off the table. The next best thing would be elimination. You can think of elimination as regional eradication. So in other words, you're eradicating a big geographic area, but not the entire world. An example would be malaria. Malaria, which was pervasive throughout North America during the 1800s, was eradicated in the 20th century from North America, meaning that eliminated, meaning that there is no naturally occurring malaria that occurs on our continent. That's an example of elimination. Think of it as a regional eradication. Again, there's some people who believe that elimination still is possible, but I would tell you that even those places where it appeared that elimination might be feasible, think New Zealand, Israel, as success stories. this really still is quite an ambitious goal, and many feel that long-lasting, durable elimination is not going to be possible in the US due to the unevenness of our vaccine coverage. In other words, that vaccine coverage is so variable in different places around the country. So that leaves us with cohabitation, which frankly is the goal of where we would most likely end up in the United States, in the UK, and in other places on the globe. Okay, this is where COVID exists, but the pandemic does not. So in other words, that there is, remember that early slide I showed you with that baseline level of endemic disease, that we end up there at some point, and we call that success. So vaccine-mediated protection in these regions prevents the most severe COVID-19 disease. We don't see those volatile pandemic fluctuations of a new wave that comes out of nowhere, like wave 4, and decimates a region. That stuff doesn't happen anymore. But instead, there is what we epidemiologists have come to calling tolerable endemicity, an acceptable level of baseline endemic level of disease. Okay, that's most likely the future, and so we're making that the goal. When we get there, there will be sporadic outbreaks, but they won't be occurring among the vaccinated. It will occur. The outbreaks will occur among the unvaccinated. Unfortunately, this scenario is not going to be a universal scenario for the whole world. There will be places of the world that don't have the access to the vaccine that we have in this country. And for them, the future is conflagration, which is basically what we have now. This is not only that level, that moderate endemic level of disease, but also these robust fluctuations, these peaks that come out of nowhere and cause these waves of disease. And that's because, again, they'll never reach the level of community coverage as we have in the United States. And I don't want to use the H word because I know that sends different messages to people of herd immunity. We're certainly not talking about herd immunity in the United States, but we are starting to reach the point where there are enough people who have been immunologically protected from the vaccine, and people that have gotten sick and survived, who've not died from COVID, but lived and have some natural immunological protection from that. We're getting to the point that between the vaccinated and the people who got COVID and survived, that we're starting to reach points where there are regions, and again, I don't want to use the H word, of community level protection. All right, I'll just say that. And so the goal is to find more and more of those regions. What happens next in the epidemic curve? I want to show you a few slides as we sort of round this out. I'm going to show you two big models that most are turning to for guidance as to what the rest of the epidemic looks like. The first is the Institute of Health Metrics and Evaluation. This is at the University of Washington. It's run by my colleague, Chris Murray. This is the primary tool that the White House Coronavirus Task Force was using during the Trump administration, still used now during the Biden administration. This is what Chris and the IMHE model says. This is the number of daily new cases. You can see, and this is not from the beginning of the pandemic. So this actually right here is wave 3 that you're seeing. You note that this doesn't go all the way to the left. This is just the last few months. So you see wave 3. Here you see wave 4. This is where we are today. And you can see that he predicts the most likely scenario being the purple line, which is that cases rise very minimally from where they are now, but we don't get the large seasonally expected holiday spike that we saw that wiped us out during wave 3 in 2020. What's the difference between last holidays and this holidays? Why are we not going to see the massive wave that we saw last, Thanksgiving, Christmas, and into New Year's? Why are we not going to see that? Vaccination. That's the game changer. That's what's different. Last year, we didn't have vaccination. The only people who had any protection were those who got sick and survived. Now we have, hundreds of thousands, millions and millions of individuals who are fully immunized. And that's going to absolutely blunt the impact of people getting together for the holidays. And so this model demonstrates the most likely scenario. We get a little bit of an increase, but largely flat as we go into the spring, which is where finally it would start to come down. The green line and the red line. The red line is what could happen if what would happen if we woke up tomorrow and abandoned all of our public health protections, if masks went away, if nobody further got vaccinated after today, what would happen would be the red line. And what you see in the green line is what would happen if we had universal masking. So you can see that if tomorrow we woke up in a world where there was 95% mask compliance, the green line is what would happen. That's not, of course, going to happen. Right now, nationally, mask compliance hovers around 30%. However, if tomorrow we could wave a magic wand and masks were at 95% usage, the green line is what would happen. That single change would lead to the green line, just to show you the impact in limiting transmission that masks have. I didn't want to leave you with just one model. So you've heard me refer in other meetings, not just to the University of Washington model, but to the COVID scenario modeling hub, which is, excuse me, a consortium of 9 academic institutions that advises the CDC on modeling. This is what they say. Oh, I'm sorry, I forgot to throw this one in here. This is the same IMHE model, but instead of active cases, this is deaths, and you see it essentially mirrors the expected worst case and best case scenarios. So here's the COVID-19 scenario modeling hub forecast. If you remember, this is predicated on 2 big caveats. Caveat number 1 is that the vaccine is approved for those ages 5 to 11, which, if you've been watching the news, has now happened. Second part of that caveat is that there is significant uptake within that cohort, which remains to be seen. That's caveat number 1. Caveat number 2 is that no Delta-like super spreader variant emerges. So in other words, we don't end up with another Delta. If those 2 things happen, significant enough uptake in the 5 to 11 population, things continue along the same track in the older population, and there's no emergence of a Delta-like super spreader variant, then this first scenario A is what our future says, this model says. And you'll note there's definitely no seasonal spike associated with the holidays, but instead nothing more than a gradual and continuous drop in new cases. These are mix-ups of that scenario. So in this case, you see that there's no new variant that emerges, but there also is no childhood vaccination. Down here, you see no vaccination and the emergence of a new variant leading to this increase. But best case scenario, glass half full, no new variant of akin to Delta, and uptake in the pediatric population gets us, according to this model, with this graph. So this is what the most likely scenarios are for where we go from here. We've had to continually reassess what success means in COVID-19. Early on, it was thought that no COVID was possible. As I mentioned earlier, not going to be possible. Even elimination is questionable whether we'd ever be able to attain that. So what is success? There are several schools of thought when it comes to that, but I want to share with you what mine is. Many epidemiologists are coalescing around influenza morbidity and mortality. In other words, it's thought that society has come to accept the level of death and illness from influenza as just something we're willing to live with and continue leading our lives. That being the model, it's thought that if we get to the point that we can get mortality, that's death, and morbidity, that's illness, down to seasonal flu-like levels. So when we get those numbers to what they would be in an average flu year, that's going to be the point at which we say, although COVID exists, and for the rest of our lives, we'll continue to have it, all right? The pandemic will be over, and things will be whatever comes after COVID will be what we have. That we reach that goal when we get to 100 deaths a day and about 5,000 new cases a day, and these models predict that'll happen in the spring. So I want to end on this. John F. Kennedy, and some of you I know are history buffs. John F. Kennedy, who only a few years later would end up navigating through the Cuban Missile Crisis, said that when written in Chinese, the word crisis is composed of two characters. One of those characters is danger, and the second character, when looked at alone, is the word opportunity. My advice as we've gone through the pandemic experience has evolved as we've learned more about this pathogen and what the future holds. In the beginning, it was thought that if we just locked down, we could get through this and emerge as if we were in a pre-COVID reality. There will be no pre-COVID future. In other words, we're not ever going to get to the point that we were before COVID. So we need to shift our focus, okay? We need to shift our focus to, to a different philosophy. And that philosophy being, how do we move on, understanding that COVID will exist throughout our lifetime. The pandemic will end, but we will be living with COVID at some low level for the rest of our lives. And that requires a shift in thinking from lockdown instead to, as we loosen the bolts, how do we keep safe during the darkest time of COVID? How do we do those things we love? How do we still make the memories that we cherish? And how do we do it in a fashion that's safe and maintains both our physical and our mental well-being? The goal is not to reach a pre-COVID normal, but to emerge from this experience stronger and more resilient than we were before we went in. There's a lot I wasn't able to cover in only an hour, but as Jean mentioned, I'm part of the health and wellness team at Adelphi, and we eagerly would answer any further questions or clarifying points that you've got. You can reach us at Health and Wellness, A&D Wellness, at adelphi.edu. You can also reach out to me personally through here. Thank you for the last hour. I hope I achieved the goal I wanted to, which is to basically have you leave with something that you didn't have when you came in. And I just want to assure you that as we get through this next chapter and the last chapters of COVID, that myself and the health and wellness team will continue to use the best available information we have to navigate Adelphi through the pandemic in a way that, like I said, we emerge on the other end even more resilient than when we went in. So thanks. And Jean, I don't know if you have any last comments before we break.
No, just Dr. Rondello, I just want to say thank you for your expertise, your leadership during the past 2 years. We are fortunate to have a faculty member of your prestige and expertise at Adelphi University. And I wanted to once again thank all of the faculty, the students, the employees, the alumni, and parents that joined us at today's forum. So everyone, be safe, enjoy your day, and we will see you hopefully soon on campus. Take care, everyone.